Hi, this is from Docs Upgrade. As we have already discussed three most important essays of the upper limb, which are the mammary gland, radial nerve and the brachial plexus in our before lectures, we'll be discussing about the last and the fourth most important essay of the upper limb, which is the shoulder joint or the glenohumeral joint. In order to make you understand easily, glenohumeral joint will be depicted in a diagrammatic explanation. So, glenohumeral joint is basically the place where the head of the humerus gets engaged with the glenoid cavity or the socket of the scapula. The capsule of the glenoid cavity is attached to the head of the humerus. The deltoid is superiorly related to the glenohumeral joint and it has three fibers: the anterior fibers, posterior and the middle fibers. The anterior fibers basically shows flexion and medial rotation. The posterior fibers shows extension and lateral rotation. The middle fibers, which is the acromial, it shows abduction, which is from the 15 to 90 degree. The coracohumeral ligament, it is a thick band and extends from the root of the coracoid process to the neck of the humerus. The Supraspinatus is superiorly related to the glenohumeral joint and is one among the rotator cuff muscle that strengthens the ligaments of the glenohumeral joint. The next one is the glenoid cavity of the scapula. The glenohumeral ligament extends superiorly from the superomedial margin of the glenoid cavity. And then the glenoid labrum. The glenoid labrum is attached to the periphery of the glenoid cavity of the scapula and is structurally fibrocartilage. This diagram shows the interior of the shoulder joint. So the glenohumeral ligament is divided inferiorly into three parts. The superior band is attached to the upper end of the lesser tubercle. The middle band is attached to the lower end of the lesser tubercle and the inferior band is attached to the lower part of the anatomical neck. In this diagram, you will be able to see the coracoid process, which is already discussed in the previous diagram. Transverse humeral ligament is another type of ligament which bridges the greater and the lesser tubercle. The glenohumeral joint is deficit in the region of bicipital group for the passage of tendon of the long head of the bicep and the synovial sheath. Let us move on to the subscapular bursa. The capsule basically has two openings, for the subscapular bursa and for the long head of the bicep. The synovial membrane basically lines the inner surface of this capsule and extends on the long head of the biceps as tubular extension, and it communicates with the synovial membrane of the subscapular bursa. Now, I'll be explaining you the movements of the glenohumeral joint. Let us start on with the flexion. Flexion is shown by the anterior fibers of the deltoid and the clavicular fibers of the pectoralis major. Extension is shown by the posterior fibers of the deltoid with the latissimus dorsi. Abduction is shown by the supraspinatus, middle fibers of the deltoid and by the fibers of the serratus anterior attached to the inferior angle of the scapula and by the serratus anterior through the shoulder girdle. Adduction is shown by the sternal fibers of the pectoralis major and the latissimus dorsi. Glenohumeral joint also exhibits circumduction, which is the combination of all movement that also includes medial rotation and lateral rotation. Now, I'll be telling you how the descriptive format of the essay regarding glenohumeral joint must be written. It should include all these sections, which are classification, ligament, movements, relation, and the most important section, which is the applied anatomy. Now, let us start on with the classification. Glenohumeral joint is structurally a multi-axial ball and socket synovial joint and functionally it is diarthrosis. What does diarthrosis mean? Diarthrosis basically means a freely movable joint that allows movement in all possible directions. Now let us move on to the ligaments. The first bifurcation on the ligaments is the capsule. The capsule is attached to the anatomical neck of the humerus, and in case of the scapula, it is attached to peripheral margins of the glenoid cavity, including the supraglenoid tubercle but excluding the infraglenoid tubercle. Because of the passage of tendon of long head of biceps, the synovial sheath and the ascending branch of anterior circumflex humeral artery, it is deficient in the region of bicipital groove. Now let us move on to laxity. What does laxity actually mean? Ligamentous laxity is a medical term for loose ligaments which can lead to loose joints that bend more than the usual. So in case of glenohumeral joint, lax is on the inferior side, which is 1 centimeter below the surgical neck of the humerus. It is strengthened by the rotator cuff. In order to remember all the muscles that come on the rotator cuff, remember the mnemonic SIT, where S stands for Supraspinatus and subscapularis, I for infraspinatus and T for teres minor. The capsule has 2 openings, for the long head of the biceps muscle and for the subscapular bursa. The second bifurcation under ligaments after the capsule is the synovial membrane. The synovial membrane lies the inner surface of the capsule and has tubular extension and extends on the long head of the biceps, and this tubular extension communicates with the synovial membrane of the subscapular bursa. The next one is the glenoid labrum. Glenoid labrum is structurally fibrocartilage in nature and triangle in cross section. It is attached to the peripheral margins of the glenoid cavity. The significance of the glenoid labrum is that it deepens the cavity of the shoulder joint, it protects the edges of the articulating surfaces, and it provides the cushion to head of the humerus to roll as the ball bearings. Let us move on to glenohumeral ligament, which is a condensation of the anterior part of the capsule. It extends superiorly from the superomedial margin of the glenoid cavity, and inferiorly it is divided into 3 parts. The superior band is attached to the upper end of the lesser tubercle, middle band is attached to the lower end of the lesser tubercle, and the inferior band is attached to the lower part of the anatomical neck. Let us move on to the coracohumeral ligament. It is a thick band in the upper part of the fibrous capsule, and it extends from the root of the coracoid process to the neck of the humerus. The last ligament is the transverse humeral ligament. It bridges the greater and the lesser tubercle. Let us move on to the next important section, which is the movements, and in this section we will be learning many mnemonics. The first movement is the flexion, which is shown by the anterior fibers of the deltoid and the clavicular fibers of the pectoralis major. In order to remember this, remember the mnemonic phase, where A stands for anterior fibers of the deltoid and C for the clavicular fibers of the pectoralis major. Extension is shown by the posterior fibers of the deltoid and the latissimus dorsi. In order to remember this, remember the mnemonic HELP, where P stands for posterior fibers of the deltoid and L for the latissimus dorsi. Now let us move on to abduction. For every 15 degree of abduction, 10 degree occurs at the shoulder joint and 5 at the shoulder girdle. 1 to 15 degree is shown by supraspinatus, 15 to 19 degree by the middle fibers of the deltoid, and 90 to 120 degree by the fibers of the serratus anterior attached to the inferior angle of scapula, and the last 120 to 180 degree is by the serratus anterior through the shoulder girdle. Remember the mnemonic SIMS, where S stands for supraspinatus, I for the inferior angle of scapula, M for the middle fiber of the deltoid, and the last S for the serratus anterior through the shoulder girdle. And now let us move on to adduction. Adduction is shown by the sternal fibers of the pectoralis major and latissimus dorsi. The last movements are the medial rotation and the lateral rotation. In order to remember the muscles that come under medial rotation, remember the mnemonic ladies, soldier and majors, which are the medial rotators, that is, muscles forming posterior boundaries of axilla, namely latissimus dorsi, subscapularis, The two majors, which are the pectoralis major and the teres major, and the anterior fibers of the deltoid. Let us move on to the last rotation, which is the lateral rotation. Remember the mnemonic tip, where T stands for teres minor, I for infraspinatus, and C for posterior fibers of the deltoid. Now, let us move on to the relations of the glenohumeral joint. Superior, inferior, anterior, and the posterior relation. Let us start on with the superior relation. In order to remember the superior relation, remember the mnemonic CDS square, where C stands for coracohumeral arc and D stands for deltoid. The last two S stands for subacromial bursa and the supraspinatus. Inferiorly, it is the long head of the triceps. Remember the mnemonic CS square in order to remember the anterior relation, where C stands for coracobrachialis and the 2S stands for short head of the biceps and the subscapularis. All these three muscles are deep to the deltoid. Remember the mnemonic I am tidy in order to remember the posterior relation, where T stands for teres minor, I for infraspinatus and intrascapular, which is the tendon of the long head of the biceps, and D for the deltoid. Let us move on to the last most important section, which is the applied anatomy. The shoulder joint is the most frequently dislocating joint in the body. It is due to the disproportionate articular surfaces of the head of the humerus and the glenoid cavity of the scapula. And the other reason is the laxity of the scapula, and the definition for laxity is already discussed before. As the capsule is lax inferiorly, and hence inferior dislocation is the most common one. When the arm is forcefully abducted, the axillary nerve is usually injured. And the next applied anatomy is the frozen shoulder, which is a common condition due to adhesion between the rotator cuff. So in order to remember the muscles of rotator cuff, remember the mnemonic sit and humeral head, resulting into the painful and restricted movement. The last one is the shoulder tip pain. Irritation of the diaphragm causes the referred pain to the shoulder tip. Now you might wonder, how does diaphragm play a role here? Since the root values of phrenic nerve supplying the diaphragm and the supraclavicular nerve supplying the shoulder joint are the same, that is the C3 and the C4 spinal segment, the irritation of the diaphragm causes the shoulder tip pain. As we have already discussed about the applied anatomy, this picture shows the frozen shoulder, which is due to the adhesion between the rotator cuff and the humeral head. Now let us move on to the most interesting section that evaluates yourself. That is the previous year MCQs. Let us start on with the first one. The following movements occur at the shoulder joint: abduction, adduction, supination, flexion, and circumduction. Among these 5 movements, only 4 movements occur at the shoulder joint. Have you guys found out what the answer is? Let us move on to the next slide to find which one is the odd one out. The odd one out is supination. Supination is a movement that does not occur at the shoulder joint but occurs at the forearm. Now let us move on to the second MCQ. The following structures are the static stabilizers of the shoulder joint: supraspinatus, glenoid labrum, subscapularis, middle glenohumeral ligament, and the inferior glenohumeral ligament. Among these 5, there are 2 options which are wrong. So find out what that is. And let us move on to the next slide to find out the 2 odd one outs. Supraspinatus and the subscapularis are the rotator cuff muscle that are dynamic stabilizers of the shoulder joint. So, only the glenoid labrum, middle glenohumeral ligament, the infraglenohumeral ligament are the following structures which are the static stabilizers of the shoulder joint. So I've already told you, remember the mnemonic sit to remember all the muscles that come under the rotator cuff. Let us move on to the last question, that is abduction of the arm at the glenohumeral joint from the 0 to the 180 degree requires the active involvement of trapezius, the active involvement of serratus anterior, intact fibers of the 8 cervical spinal nerve, an intact radial nerve, or an intact axillary nerve. Find out 2 options which are wrong among the 5 options that are given here. I guess you guys would have definitely found out what the 2 options are. Radial muscle does not innervate any of the prime abductors of the shoulder joint. An abduction from the 90 to 180 degree, it requires scapular rotation, which is only possible by the trapezius and the serratus anterior. So, it does not require intact fibers of the 8 cervical spinal nerve and an intact radial nerve. I guess you guys would have understood glenohumeral joint very well. Our next lecture will be on important short notes of the upper limb. To upgrade and enrich your medicine in the fingertips and to also get updated with the shortcuts and techniques, do subscribe our channel.